You know that really unsettling feeling, right? A fever that just won't break, maybe chills that shake you right to your core.
Mhm.
That sense that something's really wrong, but you can't see the enemy.
Yeah, it's invisible.
Exactly. So today we're diving deep into a really critical diagnostic tool that helps solve that exact mystery, the blood culture.
Think of it like a medical detective story.
Yeah, like we're hunting for these tiny unseen invaders lurking right there in your bloodstream.
And our mission, really, in this deep dive is to unpack how this test, which seems pretty straightforward, actually confirms bloodstream infections,
Okay.
how it precisely identifies the microbial culprits, the specific germs, and maybe most importantly, how it guides life-saving treatment.
So it's kind of a shortcut to understanding why it's the gold standard for diagnosing some really serious infections.
That's exactly it. It's the gold standard.
And for you, our listener, understanding this whole process,
Mhm.
I think it gives you a new perspective on the precision and, frankly, the urgency behind medical diagnostics,
Yeah,
especially when you're talking about things like sepsis.
absolutely. Sepsis is critical.
So let's start right at the beginning. What is a blood culture exactly?
Mhm.
And why does finding, anything in the blood matter so much?
Okay, so basically, a blood culture is a lab test. It's designed specifically to find pathogenic organisms, so bacteria or fungi, that have got into the bloodstream where they shouldn't be.
Right, because blood's supposed to be sterile.
Exactly. Normally, your blood is a totally sterile environment. It's like a closed highway system, totally free of uninvited guests.
Okay.
So if we find any microorganisms hanging out in there, it's like an immediate flashing red light, big warning sign.
Mhm.
It tells us there's a significant problem.
But a positive culture, that just means you found something, right? Not necessarily the bad guy.
That's right. A positive culture means we've recovered organisms, but
Sure.
then, like you said, the real detective work starts. Is this the true villain causing the illness, or is it just maybe a harmless bystander that accidentally got scooped up in the sample? Distinguishing that is crucial.
Okay, so if blood is normally sterile, finding anything raises the stakes immediately.
Yeah.
What are we actually trying to achieve with this test? What are the main goals?
Yeah, the goals are very clear, almost like steps in a forensic investigation. First, simply confirm that microorganisms are actually present in the bloodstream, not just suspected, but confirmed.
Got it. Step one.
Step two, identify the specific microbial culprit. Is it a particular bacterium? Is it a type of fungus? We need the exact ID.
Okay.
Third, this can often help pinpoint the source of the infection. Where did it come from? A lung infection, a UTI.
Ah, okay. Track it back.
Exactly. And maybe the most critical piece, a positive culture, gives us a pure sample of the organism for something called antimicrobial susceptibility testing, or AST.
AST, and that tells you.
That tells us precisely which antibiotic is going to be the most effective weapon against that specific bug. It's vital for choosing the right treatment.
That's like finding the criminal, figuring out their MO, and then knowing exactly what their kryptonite is.
That's a great analogy. Yeah, exactly that.
So what are the initial signs? What clues would make a doctor think, okay, we need a blood culture here?
Well, the clinical clues are often pretty dramatic, suggesting a systemic infection, something affecting the whole body, things like a high fever, or sometimes surprisingly, hypothermia, an abnormally low body temperature.
Oh, interesting. Okay.
Yeah. Also, chills, really noticeable chills, rapid breathing or a very fast heart rate, confusion, especially sudden confusion, a drop in blood pressure, extreme fatigue, like debilitating tiredness, or even changes in skin appearance, like mottling. These are all urgent signals.
And I guess certain people are just more vulnerable, right? They'd be prime candidates for this kind of investigation.
That's absolutely right. We have high-risk groups. These include people who are immunocompromised, maybe they're undergoing cancer treatment, have an autoimmune disease, HIV/AIDS, or are on immunosuppressive therapy.
Okay.
Also, newborns are very vulnerable. Young children with unexplained fevers, and older adults too. Their immune systems might not be as robust.
Makes sense.
And, if these severe blood infections, we call it septicemia, aren't caught and treated super quickly, the consequences can be really dire. It can rapidly lead to multi-organ dysfunction, even organ failure. That's why the test is so urgent. There's no time to waste.
Wow. Okay. So thinking back to what you said about distinguishing the real culprit from a contaminant,
Yeah.
the way the blood sample is actually collected must be absolutely critical, like securing a crime scene, right? Avoid those false leads.
You've absolutely hit on a core truth there. The meticulous art of collecting that blood culture, it's paramount.
Mm.
Seriously, it is the first line of defense against accidentally introducing contamination, usually from the patient's own skin.
Skin bacteria, yeah.
Exactly, skin flora. And that contamination can be a huge challenge. It can lead to false positives, sending the whole investigation down the wrong path.
So it's definitely not just a quick alcohol wipe then, huh? What's the proper way to prep the site?
Oh, far from it. Site prep is a really critical step. We're talking meticulous cleaning of the spot where the needle goes in the venipuncture site. We use a powerful antiseptic, usually chlorhexidine or sometimes iodine.
Okay.
And here's a detail that often gets missed but is super important. You have to let it air dry completely,
Why is the drying so important?
because that air drying time allows the antiseptic to actually work, to kill the maximum number of bacteria on the skin surface before the needle ever touches it. It's about maximizing its killing power. Patience is key there.
Got it. And I've heard the amount of blood collected is also really specific. You can't just take a random amount.
Precisely. Volume matters a lot. The yield of pathogens, the chance of actually finding them if they're there, increases proportionally with the volume of blood cultured, up to a certain point, of course.
So how much are we talking?
Well, for adults, the standard recommendation is often around 16 to 20 milliliters per set, and that's usually split between two different bottles. One for aerobic organisms, those that like oxygen, and one for anaerobic ones, those that prefer no oxygen.
Ah, okay.
Yeah.
Covering both bases?
Exactly. But for kids, especially infants, the volume is much smaller. We use special pediatric bottles and typically collect only 1 to 3 milliliters. It's carefully calculated based on their size.
Now, this is where I think the strategy gets really interesting, separating the real threats from just, like, background noise. You mentioned taking multiple samples from different sites. How does that work as a lie detector?
Yes, this is a brilliant part of the process. It's all about increasing certainty. The standard recommendation is to collect 2 or more blood culture sets, and crucially, they should be drawn from different venipuncture sites, like one from the left arm, one from the right arm.
Okay, why different sites?
Well, think about it. If a common skin bug, one of those usual imposters, shows up in only one of those sets, drawn from one site, it's much more likely that it was just a contaminant picked up during that specific needle stick.
Right, a fluke.
Exactly. But if the same organism grows in multiple sets, drawn from different locations in the body, the probability that it's a true bloodstream infection goes way, way up.
Okay, so the pattern tells the story.
Precisely. It helps us differentiate true Bacteremia bacteria genuinely circulating in the blood from contamination. It also increases the chance of detecting bacteria that might only be present in the blood intermittently, not constantly.
And what about the timing? Is there a perfect moment to draw the blood, like before antibiotics?
Ideally, yes. The best time is before any antibiotics are given.
Why is that?
Because antibiotics can inhibit or kill the bacteria in the bloodstream, making it much harder or even impossible for them to grow in the culture bottle. That leads to a false negative beat at them. The infection is there, but the test misses it.
So you miss your chance.
You do. Now, sometimes, if a patient is already on antibiotics, we might try to draw cultures right before the next dose is due, when the antibiotic level might be lowest, or maybe after a 24-hour break if clinically safe. But getting it before any treatment starts is always the gold standard.
Okay, and I've also heard it's generally better to use a fresh needle stick in a vein, like in the arm, rather than drawing from an existing IV line or a central catheter, even though that might seem easier.
That's another really crucial point for accuracy. While drawing from an IV catheter might seem convenient, those lines, especially ones that have been in place for a while, have a much higher risk of being colonized with bacteria that can develop their own little bacterial communities.
Biofilms and things.
Exactly. So drawing through them significantly increases the chance of getting a contaminated sample. Whenever possible, the preferred method is a fresh peripheral venipuncture, a new needle stick into a vein to get the cleanest possible sample.
Makes sense. And then, once collected, straight into those special bottles.
Immediately. Direct transfer into the aerobic and anaerobic culture bottles to start the incubation process without delay.
Okay, you mentioned the contamination problem, those imposters. What are some of these common false alarms we might see? And what's the real impact when you get a false positive?
It can't be good.
No, it's definitely not good. The usual suspects for contamination are bacteria that normally live harmlessly on the skin. Things like coagulus-negative staphylococci, that's a big one. Also, Corynebacterium species, certain bacillus species that aren't Bacillus anthracis, of course, and Cutibacterium acnes, the bug formerly known as Propionibacterium acnes.
So, Common skin bugs.
Very common. And the impact of a false positive is actually pretty significant. For the patient, it often means getting unnecessary antibiotics.
Which isn't harmless, not at all. It exposes them to potential side effects, allergic reactions, and it contributes to the huge global problem of antimicrobial resistance. Plus, it can lead to longer hospital stays, more diagnostic tests being ordered, chasing this phantom infection, increased healthcare costs, and sometimes even unnecessary procedures like removing a central line they might actually need.
Wow. So it has real consequences.
Absolutely. It's a major issue, which is why clinical microbiology labs track their contamination rates very carefully. The goal is typically to keep them below 3%, ideally even lower, like less than 1%. It's a key quality metric.
Okay, so let's follow the sample. It's collected properly, hopefully avoids contamination, goes into the bottles. What happens next in the lab? How do they actually start solving the mystery?
Right. So in the lab, those bottles go into specialized automated incubation systems. These machines are like vigilant sentinels. They continuously monitor the bottles for any signs of microbial growth.
How do they detect growth?
Usually by detecting gases produced by the microbes as they metabolize the nutrients in the broth inside the bottle. Carbon dioxide is a common one. So the system has sensors that detect increases in CO2.
Deliver.
Yeah, it's pretty neat. When the system detects growth crossing a certain threshold, it flags the bottle with a positive alert. The instrument alarms and the lab staff are notified immediately.
And they let the doctors know right away.
Yes, prompt communication is key. The lab alerts the clinical team quickly that a blood culture is positive. This is often the first concrete sign of a bloodstream infection.
Okay, so the alarm goes off. What's the lab's first move then?
The very first step usually is to perform a gram stain directly from the positive broth in the bottle.
The gram stain, right. What does that tell them quickly?
It gives really rapid preliminary information. It tells us if the organism is gram-positive staining purple or gram-negative staining pink. It also shows us the shape. Are they round kochi or rod-shaped bacilli? And how are they arranged? In clusters, chains?
Like a quick sketch of the suspect.
Exactly. It's not a final ID, but it's valuable information that gets reported back to the clinicians immediately, often within an hour of the bottle flagging positive. This can help them start refining that initial broad-spectrum antibiotic therapy.
Okay, so they have the sketch. How do they get the full ID, the name, and everything?
So, after the gram stain, the lab takes a drop of that positive broth and streaks it onto agar plate solid growth media. This is called subculturing. We need to grow the organism in pure culture to get enough of it for definitive identification and testing.
Makes sense.
Then, once we have isolated colonies growing on the plates, usually the next day, we use more advanced methods for the final ID. This could involve traditional biochemical tests, seeing what sugars the bug ferments, what enzymes it produces.
The old school way.
Kind of, yeah, but still very useful. Increasingly, labs use faster methods like mass spectrometry. MALDI-TOF MS is a big one.
MALDI-TOF. Sounds fancy.
It is pretty cool. It basically analyzes the unique protein fingerprint of the microbe. It zaps the colony with a laser, identifies the proteins based on their mass, and compares that profile to a huge database. It can often give an accurate species ID in minutes.
Wow, that's fast.
It really revolutionized microbial ID. And some labs also use molecular methods like PCR, sometimes even directly from the positive blood culture broth, to rapidly detect specific pathogens or even important antibiotic resistance genes.
Okay, so now they've got the culprit identified, nailed it down, but you still need to know its weaknesses, right? That's the AST part.
Exactly. Knowing the enemy is half the battle, knowing its weakness is the other half. Once we have that definitive identification, we perform antimicrobial susceptibility testing, or AST.
How does that work? Like tiny battle simulations?
That's a good way to put it. We essentially challenge the isolated organism against a panel of different antibiotics in the lab. There are various ways to do it: disc diffusion, automated systems that measure growth in tiny wells with different antibiotic concentrations.
Right.
Basically, we're seeing which antibiotics effectively inhibit the organism's growth or, ideally, kill it. The results tell us if the bug is susceptible, likely treatable with that drug, intermediate, maybe treatable with higher doses, or resistant, that drug probably won't work.
So this is the crucial bridge to targeted therapy.
Absolutely crucial. This AST result is what allows doctors to move from that initial broad-spectrum guess to a precise, targeted attack against the infection.
Which brings us neatly to interpreting these results and guiding treatment. And this ties into something called antimicrobial stewardship. Could you just quickly unpack what antimicrobial stewardship really means for our listeners and why it's so vital here?
Yeah, absolutely. Antimicrobial stewardship is it's fundamentally about the responsible use of antibiotics. It's a coordinated effort to ensure that we're always prescribing the right antibiotic for the right infection at the right dose, using the right route like IV or oral, and for the right duration.
Okay, so it's about being smart with our drugs.
Exactly. The main goals are to optimize clinical outcomes for the patient, make sure the treatment works, but also, critically, to minimize unintended consequences like toxicity, side effects, and especially the development of antibiotic resistance.
Resistance is the big one, right?
It's a massive global health threat. Stewardship is our long-term strategy in this ongoing war against evolving bacteria, making sure our current and future antibiotics remain effective for as long as possible.
Got it. So how do these blood culture results, positive or negative, directly guide that stewardship process and the patient's treatment? And how does that multiple sample strategy play into interpreting a positive result?
Okay, so a negative result, no growth in any of the bottles after a standard incubation period, usually about 5 days, generally suggests there's no bloodstream infection.
Usually.
Well, we always have to consider the possibility of a false negative. Maybe the blood volume collected was too low, or maybe the patient had already received antibiotics that suppressed growth. Clinical context is still key. Now, a positive result means microorganisms were identified, and this is where the interpretation gets critical and where that multiple sample strategy is so powerful. If you have multiple culture sets drawn from different sites and they all grow the same organism, especially if it's a known pathogen like Staphylococcus aureus or E. coli, that strongly indicates a true bloodstream infection.
So the consistency across samples is the key.
It's a huge indicator. Conversely, if only one bottle out of, say, 4 bottles drawn grows a common skin contaminant like coagulous negative staph, that leans much more towards contamination. It helps the clinical team weigh the likelihood.
That makes sense. It's like having multiple witnesses telling the same story versus just one shaky account.
That's a perfect analogy.
Now, given how serious sepsis can be, I imagine doctors don't just sit around and wait for all these definitive results before starting some kind of treatment.
Oh, absolutely not. You're exactly right. Waiting is not an option when sepsis is suspected. Clinicians initiate what's called empirical therapy.
Empirical meaning.
Meaning, based on observation and experience, essentially an educated guess before all the facts are in. They start broad-spectrum antibiotics drugs that cover a wide range of potential bacterial culprits before the culture and susceptibility results are back.
Okay.
This decision is based on the patient's clinical picture, their symptoms, where the infection might be coming from, like lungs or urine, their risk factors, and local patterns of common infections and resistance. This early, broad coverage is absolutely crucial for improving outcomes. It significantly reduces mortality rates and can shorten hospital stays. Every hour delayed can worsen the outcome in sepsis.
So start broad, save the patient. Then what happens when the lab results come back with a specific ID in the AST?
That's when the power of the blood culture really comes into play for stewardship. Once the specific microorganism is identified, and crucially, its antibiotic susceptibility profile is known typically within 24 to 70 hours, the antibiotic therapy should be adjusted.
Adjusted how?
This is where de-escalation or narrowing the spectrum happens. If the initial broad-spectrum drug is still appropriate based on susceptibility, great. But often the results allow the team to switch to a narrower spectrum antibiotic one that specifically targets the identified pathogen while sparing other beneficial bacteria in the body and reducing the pressure for resistance.
So moving from a shotgun to a sniper rifle.
Exactly. That's the core principle of stewardship in this context. Using the right drug for the right bug for the right duration. It's about being as precise and targeted as possible.
And do they always need to do repeat blood cultures later to make sure the infection is gone?
That's a good question. It depends. Repeat blood cultures are often necessary to document clearance of the bloodstream, especially for certain tenacious pathogens like Staphylococcus aureus or Candida species, which can hide out or cause complications like infections on heart valves. They might also be done in cases of suspected endovascular infection, like endocarditis. Or if the patient isn't improving as expected, maybe their fever persists despite what seems like appropriate antibiotic therapy.
But not always.
Not always. For many common bloodstream infections, especially uncomplicated gram-negative bacteremia, if the patient is clearly improving clinically on targeted therapy, follow-up blood cultures are often considered unnecessary. The clinical response is often a sufficient indicator that the treatment is working.
It's really fascinating how these core diagnostic principles, this whole detective story, isn't just limited to humans. How does this look when we shift focus to animal health? Say, horses, for example.
It's remarkably similar, actually, which really highlights the universality of these biological challenges and diagnostic approaches. What's quite interesting in horses is the epidemiology. While a positive blood culture is relatively uncommon in adult horses,
Okay.
it's actually most common in neonatal foals suffering from septicemia. Just like human newborns, they are a particularly vulnerable population.
Huh. So the risks and causes probably mirror humans in some ways, too.
They definitely can. The underlying principles of infection, diagnosis, and treatment hold true across species.
Are there specific things in a horse's history or unique signs that would make a vet think, we need a blood culture?
Absolutely. There can be specific clues. For example, in an adult horse, maybe they recently had a dental float. That's a common procedure where their teeth are filed down. If they get sick afterwards, especially if they also have an underlying condition like PPID, which is a hormonal disorder similar to Cushing's in humans that can affect immunity,
Right.
that might raise suspicion of bacteria getting into the bloodstream from the mouth. For a newborn foal, a huge red flag is failure of passive transfer or FPT.
Failure of passive transfer.
Yeah, it means the foal didn't nurse properly within the first crucial hours after birth, or the mare didn't produce good quality colostrum, that first milk packed with antibodies. Without those maternal antibodies, the foal's immune system is wide open to infection. So a history of poor nursing or low antibody levels is a major trigger for suspecting sepsis and doing a blood culture.
That makes sense. They missed that initial immune boost.
Do the signs of infection look different in adult horses versus foals? Like how symptoms can vary with age in people?
They often do, though there's certainly overlap. In adult horses with suspected bacteremia, you might see signs like fever, not eating well, anorexia, depression or lethargy, a fast heart rate, tachycardia, and rapid breathing tachypnea.
Pretty classic infection signs. Right. But importantly, just like in humans, the absence of a fever doesn't rule out septicemia, especially if other signs are present. Foals, being so young, can show less specific signs sometimes. They might just be down, unable to stand, recumbency, have a weak suckle reflex, general weakness, maybe diarrhea or signs of colic. Their vital signs can be all over the place too. Heart rate, breathing rate, temperature can be high or low. It makes diagnosis tricky.
Sounds challenging. And what about the actual culprits? Are the types of bacteria similar to what infects humans?
There are definitely parallels. In adult horses, common isolates from blood cultures include bacteria like Streptococcus species, Actinobacillus species, Pseudomonas aeruginosa, names that are familiar from human medicine too.
Okay.
Risk factors in adults might include things like having an IV catheter replaced for a while, general immunosuppression, or a local infection somewhere else in the body like pneumonia or a wound infection that seeds into the blood.
And for the foals, you mentioned the lack of immunity.
Right. For neonatal foals, gram-negative bacteria are statistically the most common culprits, especially E. coli. Their major risk factor is that failure of passive transfer we talked about. Other risks include infections of the umbilical cord stump omphalophilitis or even specific genetic immune deficiencies, like severe combined immunodeficiency, SCID, seen in Arabian foals, which has parallels to human SCID.
Wow. It really mirrors the human situation in many ways. So, thinking about the bigger picture for these sick foals, what's their prognosis generally look like?
It's serious, but there's hope with aggressive treatment. Survival rates for septic neonatal foals that receive intensive care fluids, antibiotics, nutritional support, the whole 9 yards are generally around 65 to 70%.
That's pretty good considering how sick they are.
It is, but there are long-term implications. A common complication is secondary joint infection, sometimes called septic arthritis or joint ill. If that happens, even if the foal survives the initial sepsis, it can significantly decrease their chances of having a successful athletic career later in life.
Okay. Lasting effects.
Definitely. And other severe complications can occur too, like laminitis, that painful inflammation in the hooves, or multi-organ dysfunction syndrome, MODS, similar to what happens in severe human sepsis or even meningitis. It really underscores the critical need for rapid diagnosis via blood culture and immediate intensive treatment, just like in critical human pediatric cases.
This has been such a fascinating deep dive.
Hmm.
It really drives home the incredible complexity, but also the precision involved in diagnosing something as fundamental as a bloodstream infection.
It really does.
The blood culture, it's often this unseen process happening behind the scenes for the patient, but it is truly the gold standard, isn't it, for
Yeah.
finding these life-threatening infections and guiding how we treat them.
Absolutely the gold standard.
Mhm.
And its effectiveness really hinges on every single step being done right, from that meticulous collection technique we talked about,
Right, the cleaning, the volume.
to the rapid transport, the sophisticated lab analysis, and the careful interpretation. It's a powerful example of how seemingly small details, getting the skin prep right, drawing enough blood, have these enormous, potentially life-saving consequences for getting the diagnosis right and impacting patient outcomes.
It really highlights the incredible precise work needed to pinpoint those hidden threats.
Hmm.
A real testament to medical detective work.
Couldn't agree more.
So what does this all mean for you listening? Well, next time you hear about someone dealing with a serious infection, maybe take a moment to consider that silent, unseen battle happening right there in their bloodstream. And think about the incredible science, the detailed process involved in shining a light on it.
Hmm.
It really makes you wonder, doesn't it? What new diagnostic tools, what future innovations might further revolutionize how we detect these hidden threats even faster or more accurately? How else can we make the invisible visible?